Hello, good evening, welcome everyone, and thank you for joining us tonight for our next Living with COVID update. Tonight's topic is vaccines and COVID care on the Central Coast. So my name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I'd like to begin this evening by acknowledging the First Peoples and traditional custodians of all the lands in which we are meeting on and pay my respects to elders past, present and emerging. I'd also like to acknowledge that I'm currently on Awabakal country. So tonight's session is being recorded and the recording and the presenter's PowerPoint slides will become available from tomorrow in our education library. So to access our library, it's just on our website. So you head to our homepage, thephm.com.au, and then click on the education tab. There'll be a short evaluation survey which will automatically pop up when the webinar ends. If you could just take one more minute of your time tonight before you log off and fill that out for us, we really appreciate any feedback that you can provide. We're very welcoming to your questions this evening. So you'll see in your control panel, there's a questions chat box. Please type them in there at any stage tonight throughout the presentations, but please know we have allocated time after these to go through them with our panel of speakers. So that's all from me to get things kicked off. I'll hand over now to John Bailey, who is an Executive Manager with the PHN. John will introduce this session and tonight's speakers. Thanks, John.
Thanks, Charles, and welcome everyone. Thanks for attending our next session in Living with COVID. Tonight's session, we've decided to focus on the Central Coast a little, and in 2 weeks, we'll be focusing on the rural sector. The first part of our session tonight, though, will be applicable to people from right across the region. Tonight, we have Dr. Elizabeth Renke, who's the neurologist and District Director of Medicine at Central Coast Local Health District, Dr. Michelle Redford, who's a GP at Blackbutt Doctors and clinical lead with the PHN for COVID, Dr. Karen Douglas, who's a general practitioner at Terrigal Medical Centre, Tim Garrett, Director of Pharmacy at Central Coast Local Health District, and Melissa Pickering, who's Director of Nursing, Community and Chronic and Complex Care on Central Coast Local Health District. That's a mouthful. Tonight, as we've got a whole range of topics, as I've said, that we'd like to cover, so I won't waste a lot of time. One thing I would like to do is to remind those practices who are in tranche 1 of the Novavax rollout that your ordering window closes tonight at midnight. So if you're in tranche 1, you need to place your order before midnight tonight for your Novavax supply. And I'm going to hand over to Dr. Michelle Redford. Thanks, Michelle.
Thanks, John. And thanks everybody for being here and giving up your time for this update. I'm going to just run through fairly swiftly a few bits and pieces of an update, and it's mostly going to be focused on questions that have come through. So hopefully it's all relevant and it's not going to take too long. So I'm just going to be talking about some hot topics. This is where the answers to the questions that come into the PHN live. So it's housed on the PHN website, and that's the link. So if you do have questions, please submit them and the answers will go up there. These are the few things I'm just going to talk about, things that have changed in the last couple of weeks. Just a little plug once again for Health Pathways and a couple of very quick tips. Now, sometimes we do get some feedback that people find it difficult to find things. So this is a tip that was shared by Martina Gleason actually at one of the recent RACGP webinars. And that little button at the top that I've circled, the expand all, if you expand all and then press Control F to find, you can search and you can find all the places where it says sotrovimab in that pathway, for example. So that's actually quite a useful tip. And the other button that I love on Health Pathways is the feedback button, where if you have a question or if you think that there is something that could be improved, then they're actually really responsive to feedback. They might be slightly sick of my feedback, but use that button. It's a really good service. So rats. So this is the New South Wales infographic that came out in response to the TGA, just highlighting the need to avoid certain activities before doing a saliva rat, and it's just a good reminder that rats are only as useful as, you know, the process that goes into them, really. The process has to be correct or you're not going to get a useful result. So it is important to follow the instructions. I've seen lots of things about, can you use a nasal swab to swab your throat? And apparently the answer to that is just follow the instructions in the packet. There's also some stuff going around about under 2s, and I think my understanding on that is that there are not really any rats that are tested and sort of approved in under 2s. School children and teachers and everyone that works in school are doing rats twice a week, as I'm sure lots of us are aware. And just to flag that you don't need to do that up for the first 30 days after you've been de-isolated with COVID. So that's just a couple of bits and pieces about rats. Another little handy thing for rats, this is the Find a pharmacy that has the pensioner concession rats available. So I did the search in Sydney, but of course you can find them wherever. So it's just a link there. On to boosters. So hopefully you're all now aware that 16 and 17-year-olds are now able to get a booster 3 months from their second dose. If you had a 3-dose primary course because you're a significantly immunocompromised 16 or 17-year-old, then you get a booster 4th dose 3 months, what's 2 to 3 months after your 3rd dose of your primary course. Now this is Pfizer only, no Moderna, and it's not going to be Novavax either because Novavax is 18+, so it is only Pfizer. But hopefully we get some decent uptake, and just to be clear on, that's ready and going. Why are we doing boosters? This is a useful little infographic of why we're doing boosters, and the link is over here on the side if you wanted to find it online. And really it shows that the people who stand to benefit the most from boosters are people who had 2 doses of AstraZeneca, which is over there on the left of your screen compared to 2 doses of Pfizer. And as you get older, you stand to benefit more from the boosters. So there still is a bit of a call out to focus on those higher risk groups and to make sure that all the people that are eligible for your booster do get boosted. It's just a plug for that. On to Novavax. The mandatory training module has been released. So if anybody is in the first tranche, as John said, then you do need to hop online and make sure that all of your GPs that are supervising Novavax vaccination in your facility and or anybody else that's involved in giving the vaccine has done that mandatory training. So that's live now. I did it the other day. It didn't take too long. A few bits and pieces that I learned. So you can give Novavax in pregnancy, but mRNA vaccines are preferred in breastfeeding, so not Novavax first line. It's got the same primary course characteristics really as other vaccines for severely immunocompromised people, so you give your 3rd dose 2 months after the 2nd dose. You apparently can use it for your 2nd dose if you haven't completed a primary course, so you've had 1 dose of something else, but you'd want to have a good reason for that, and there is specific target guidance around that. Comes in boxes of 100, and just remember it's not a live vaccine, it's protein-based vaccine, it's more like a hepatitis B type vaccine. Oh, sorry, skip through. That's what it looks like. It's actually got a place to write the expiry date and the time that you opened it on the vial, and it can be stored in your fridge, in your vaccine fridge for 6 months. You don't have to dilute it. How good is that? So no messing about with saline and injecting it. So that's Novavax. Novavax ingredients, because I've just put that up there because the only really sort of allergenic thing on there is polysorbate 80. And so it's actually really unlikely that people have got a contraindication to Novavax, because really the contraindications are anaphylaxis to a previous dose of Novavax or anaphylaxis to an ingredient. So it's going to be pretty unusual to find someone that can't try to be vaccinated with Novavax. So that's a good thing. Common side effects are actually quite high rates of injection site tenderness when you think about like the Pfizer vaccine, which is reported on Osvax safety about more like 30 to 40%. But these are minor side effects, and the surveillance doesn't seem to be coming up with anything too worrying at this stage. And there is a official after your Novavax patient information sheet available on that link. So that's Novavax. Just moving on to more vaccination stuff. So this is now in play. This is the mandatory vaccination of primary care healthcare workers, and everybody that works in primary care essentially is a stage 2 healthcare worker and should have at least received their first vaccine dose by now and needs to have their second dose this month or have a valid medical exemption. And just again saying that the only permanent exemption really is anaphylaxis to a vaccine or ingredient of every available COVID-19 vaccine. So it's going to be pretty unusual to have a permanent exemption. At this stage, boosters are not included in this mandate. So unfortunately, people who don't meet these requirements are now only able to provide health services really where they don't have contact with other people. So they have to meet those 2 criteria down at the bottom. So entirely from premises where there are no patients, clients and others accessing the site and with no physical contact with members of the community. So that's where we are at the moment with mandatory vaccination. So just moving on. So these are some of the most frequently asked questions. What do I do with a worker who has been diagnosed with COVID-19? And these are based on the national guidelines, the CEC song about infection control and COVID. And they have also gone through the health pathways process in New South Wales. So if you are not immunocompromised and you are well at 7 days, then the standard plan is you return day 11 with no further testing, nothing else needed. Now, if you're an essential worker and it's critical that you get back into the workplace before day 11, so days 8, 9 and 10, and you have no symptoms and you're not immunocompromised, then you can have a RAT, and if that's negative, you can return to work with continuous mask wearing and avoiding your colleagues and common areas until day 11. And then you can continue with your normal work on day 11. If you're RAT positive but no symptoms, then the suggestion is that you continue to isolate. You don't return with that continuous mask wearing because you may still be shedding virus, and you return to work day 11. So that's you're well, not immunocompromised. Another common situation, not immunocompromised, still got a cough or breathlessness or something after 7 days. And now that we're seeing quite a lot of COVID patients, this is not that uncommon. So the advice there is that if you've got persistent symptoms at planned de-isolation time, that you seek your GP assessment and stay in isolation, and that would be GP by telehealth or telephone, and then return to work day 15 if everything has settled down in the previous 72 hours fever-wise and the respiratory symptoms have substantially improved. Immunocompromised patients, as you're probably aware, have more specific and complicated de-isolation requirements, and so at the moment the suggestion is that they return day 15 and having had 2 negative RATs at least 24 hours apart. And healthcare workers who have returned post-COVID don't need to have ongoing RAT testing for the first month after they have been de-isolated, because it's not going to be helpful. They're very unlikely to become positive again in that time. Household contacts, this is complicated. So there are a few reasons why it's complicated. The first thing is the thing about isolating from the COVID case in your household, because if you don't manage to isolate from the COVID case in the household, then the official advice is that you have 7 days of isolation beyond their 7-day infectious period. The other reason it's complicated is because there's an exemption for critical workers by law in New South Wales. And I'm just going to talk briefly about how that comes into play. So, household contact. Your worker doesn't test positive throughout their isolation, for example. So that person would have 7 days of isolation from their last contact with their relative or friend that they live with, and then they should be avoiding high-risk settings for a further period. Now, that's your standard management. Now, If it is critical that that worker returns to work, then they can return to work under an exemption, but you have to do a risk assessment and you have to have risk mitigation strategies in place and make sure that you have a process for managing that. So you can't just say, oh, you know, your child's positive, you're going to come to work anyway. You know, in those first 7 days, you have to actually have a whole strategy around that person. So this is the suggestion for what that strategy should look like. So first thing is that you should have no symptoms. You should have a daily negative RAT, even on the days when you're not at work. And of course, if you test positive, then you're into COVID positive isolation. You also are not released from your other isolation requirements. So you're only released from isolation to travel to and from work and to work, not for the rest of your life. You have to wear a mask at all times at work. It's suggested that you get redeployed to somewhere where you have less contact with patients and it's less risky. You have to stay away from your colleagues, take breaks outside, and not gather without masks on. So it's quite a lot, but this is out of necessity to keep services going. It's not because the virus has changed in its characteristics or infectivity. It's so that we don't have everybody furloughed. Hopefully that makes sense. Happy to take questions at the end. Other bits and pieces that have come through on great questions. I'm loving your questions. Please send through questions. So these are other bits and pieces. So this is a Hunter, New England thing. The COVID care and community phone numbers have changed. They're up to date on health pathways. Just make sure you've got the right numbers. Somebody asked, Retronivo, how effective is it? Number needed to treat 16 outpatients at high risk of progression for severe COVID to prevent 1 hospitalization or death, but that data all came from strains that were pre-Omicron. So with Omicron, who knows, probably less than that. Probably less effective than that. Probably the number needed to treat is going to be higher. No one actually has the evidence. Somebody asked how we can treat post-COVID-19 conditions. It's an excellent question. I think we're all going to be seeing a lot more of that, and we're going to have to think about how we rehabilitate these people. There is a good RACGP guide on that, and there is the link. Another question is about leaving isolation. So you have always been allowed to leave isolation for the specific purpose of attending a testing centre to get a PCR test. Antenatal item numbers have been causing a bit of confusion. That's partly because of the way that best practice records them, but those are the item numbers. You can do the equivalent of a 16500 on the phone or on telehealth. Pediatric Pfizer, they now have the expiry date of the vaccine on the carton and the vial, which is excellent. So I'm happy about that. I don't have to go trying to work it out anymore. And one question about Johnson & Johnson vaccine, which I had to look up because that's a single dose primary course. And so those people are considered fully vaccinated if they've had a single dose of Johnson & Johnson, but still eligible for a booster after 3 months. There is a Kahoot live. It is not this one. It is on Medicare item numbers. Don't get too excited. That is the correct link for the Kahoot. This is not the question in the Kahoot because this is the question I told you all the answers to last time. But it's a bit of fun. It's more fun than reading the MBS. That's all I have to say about that. And if you still have great questions, then please submit them. This is the link. It's really good to see what people are thinking about and to share those things because you can guarantee that somebody else has the same question. And that's it for me. Okay. I'm just going to hand over to Mel, I think. So Mel Pickering, who is from Central Coast Local Health District, and she's going to give us an update on what's happening. Thanks, Mel.
Thank you, Michelle. I might just ask, can you see my slide?
Yes.
Yes, thank you. So yeah, thank you for that. So I'm Mel Pickering. I'm the Director of Nursing for Community Chronic and Complex Care with the Central Coast Local Health District. And today I have got Dr. Elizabeth Renicky joining, who will provide a bit of an update on some of the current activity that we're experiencing, as well as the Retronivo infusion clinic. And I've got Tim Garrett, who will also provide a bit of an update in regards to some of the oral therapy treatments that are coming very quickly. So first of all, I just wanted, sorry, I'll just move my slide. Just wanted to provide a bit of an update on the COVID community support team, and I guess in particular, given that there has been a change in regards to patients now being under a self-managed model, I guess part of this is just to share with you how we've had to pivot or adapt some of our services in response to that and the new referral pathways. So just to start with, the COVID community support team as part of the local health district does follow, I guess, a standardised protocol-driven approach and that short-term care and monitoring for patients that are referred to our service. We do provide remote monitoring to those patients that require it, and in particular our high-risk patients, we will provide oximeters to them so that as part of our remote monitoring we can ask, I guess, how they're travelling with their oximeter readings as well as temperature as part of their normal comprehensive assessment that we will do. The model of care does incorporate existing health and social care pathways, and we do work with other members across the local health district and with some of the GPs out in the community to provide support to our patients out in the community. So the current operating hours of our COVID community support team is 8 till 8:30, 7 days a week, and we can accept referrals via our email address, which is listed there below. What we have had to do, though, as part of some of the changes in regards to the self-management model is, I guess, adapt our service to be more of a referral in model. No longer do we touch base with all patients that are COVID active out in the community. We do rely on referrals to come in through to our service for us to then reach out to those patients and provide an initial comprehensive assessment to then determine what the ongoing monitoring will look like for those patients. The referral pathways that we have for patients to come into our service is via either GPs or GP practices, where they'll either email, primarily they do email through to us, however that we have had the odd phone call through. Medibank, so that's part of the COVID-19 care at home support line. So we do receive referrals through that pathway. We also accept referrals through any other medical officer or staff specialist that may be linked within the local health district. New South Wales Ambulance may provide a referral, as well as our emergency departments or any of our inpatient units. So there are multiple referral pathways and we do respond to all those referrals, but it is worth noting that there are a very small cohort of patients that once we do make that initial contact with them, they may decline any further ongoing monitoring from our team. We do find that just a very small cohort that may have gone through the Medibank referral, that they were really just calling because they had some initial concerns, but then when we reach out to them, they decline having that daily phone call. Part of our model of care also includes risk stratification of their symptoms and risk factors, and that's to help us to determine the frequency of the monitoring that they may require. It also, part of that will help us with identifying any patients that may be eligible for Sotrovimab. So as I said, we do provide regular observations and wellbeing checks. We do have a pathway for escalation. So we do have a medical on-call roster that is in line with the operating hours of our service. And more recently, we have had some medical officers come on as part of the team during the weekdays, which has been fantastic. Our nursing team do have the required skills to make sure that they can monitor and refer on to any relevant service providers, particularly if there is a patient that we feel they may be at the end of their COVID, but do require some ongoing support. We can refer on if required. We do help patients with navigating systems and supporting them with being able to access things like food to be delivered to their home or any medications that they may be needing to access. We will help them to navigate that. And ultimately, we're looking at providing integrated, better value care for our patients in the community. So I'll just pass over to Dr. Elizabeth Renicky to provide a bit of an update on our current activity.
Thanks, Mel. Yeah, just it has changed a lot in the last 2 or 3 weeks, we've seen a significant decline in the number of active cases on the Central Coast. I was just at a meeting today where Scott McLaughlin, the CEO, was saying that we've had more than 1,000 admissions during the Delta and Omicron outbreak into the hospitals, and that doesn't take into account the amount of people who just presented to the emergency department or the people who were treated by the community support team. So it is a little hard to know how many active cases there are on the Central Coast in total, because the PCRs and the rats are, well, some of the rats are reported, but some of the rats are not reported. But PCRs, by the nature of how they're collected and how the report is done, I think we know about all of them. And so the sort of guess is it should possibly about 4,000. Well, our public health unit today was saying that the daily figures fluctuate probably between 300 and 400. It's recently gone up to 500, maybe with children going back to school. And it certainly would be interesting as they monitor the school children to see how many of the positive rats are asymptomatic. But what we're seeing at the moment is probably mainly symptomatic people getting tested. Hospitals, up to last week, we had 2 full COVID wards, about 60 patients in Gosford and about 18 patients in Weil, and patients in both ICUs. We've only got about 4 ICU patients at the moment. They're all in Gosford now. Weil doesn't have any patients in ICU, and we still have a COVID ward on each side open, a total of about 38 inpatients at the moment today. Majority of them are firstly respiratory, about I think 14 or so respiratory, and then the second biggest group is aged care. Now, many of those people did not come in because they have COVID. They may have come in with a broken hip or with something else, but then have a temperature and then they're found to have COVID. So they're not necessarily being treated for COVID as such. In the community support team, we've currently got about 82 people registered by the methods that Mel was saying, that they are sort of referred in different pathways, and 14 of those are children. We see quite a significant amount of pregnancy patients. I think the obs and gynae group are quite active, and they have been people that I think have been, well, we think benefit from the sotrovimab. As was said earlier, a lot of the evidence of how much sotrovimab or anything for that matter works is still based on Delta virus. So some of our, so from Medibank, it's sort of the direct people opting in and going to Medibank to sort of flag that they are over 70 or they've got risk factors. We get about 15 a day perhaps, and then directly from GPs we get about 5 a day, and then we have referrals from specialists. So often hematology, oncology, renal for the transplants, the patients are referred directly because they've been told in advance to, you know, contact the specialist whenever they do become positive, and they sort of put into our system pretty smartly. Thanks, Mel. Can I have the next slide? This is just a little bit about the indications for the sotrovimab infusion clinic, and I know Tim's going to talk about the medicines, the pills. It's going to be fairly similar, so they've got to be COVID positive at this stage, even though sotrovimab is actually approved by TGA for just exposure, but we don't follow that indication here. They've got to be early on in the disease for it to be active, so not requiring oxygen, not fully vaccinated. Now this is a bit of a moving target as the sort of timing of the booster doses change. So at the moment we're saying that anybody who hasn't, you know, had 2 doses plus at least 14 days after their booster are counted as being fully vaccinated, and anybody who's edging up to about 5 or 6 months and have not yet had the booster, we don't regard as fully vaccinated either, really, because it shows that up to about 20 or 24 weeks we're still pretty much two vaccinations will still protect against hospitalization, but really not beyond 4 or 5 months. And then the other group that we see a lot of are the fully vaccinated but immune compromised. And they've been a very interesting group because so many people are on monoclonal antibodies, and it's often hard to know whether a monoclonal antibody is actually immune compromising or not. It's clear for those who are solid organ transplants or have been on long-term mycophenolate or high-dose prednisone. But we've been following the ATAGI guideline for who needs a third dose as those being significantly immunocompromised, looking at which particular biological agents are thought to be immunocompromising or not. And then they should have one of these other features as well. And it is now, as compared to a few months ago, definitely indicated in pregnancy, particularly second and third trimester. As we know that particularly the third trimester patients, if it's getting close to birth and they then have COVID, they seem to do less well than anybody else with the cytokine storm and all the changes in immunology and that kind of thing. So we do try and get to them pretty early on. And then children now over 12 and weighing 40 kilograms. I think we've done 2 so far. One was a little boy with a lung transplant. I can't remember what the other one was, but so they can safely receive the Sotrovimab. So we don't admit them to hospital, but we're using one of the houses in Holden Street. So it's arranged through the Central Coast Community Support Team, and we usually run a clinic Mondays, Wednesdays, Fridays, which is sometimes a challenge because we do want to get them within 5 days if we can. And yeah, so I think that's working pretty well actually. I think that's about it from me. I think I'm handing over to Tim about the new oral treatments.
Thanks, Elizabeth. Look, I think it's interesting what you're saying there in terms of getting better data in terms of predicting some of our demand or the activity in community. Certainly, I think one of the challenges that the ministry is needing to deal with that's going to hit us in an operational sense is in terms of availability of some of the oral agents, looking through the supply chain and I guess predicting based on case numbers and I guess how we're going to prioritize the treatments based on clinical presentation is key to us in terms of maintaining supply. Anyway, I'm grateful for the opportunity. I'm probably going to spend 5 to 10 minutes just talking through the 2 new and newly registered into provisionally registered TGA treatments for COVID-19. We've got the Molnupiravir, and I'll also talk around a combination product that's Nimatravir and Retronivo. That combination product is known as Paxlovid. Someday these names will get a little bit easier. I'm sure it's covert marketing by our pharma colleagues to try and make sure that their generic branding is still there, but let's see how we go. So on both of these new agents, the first section around the provisional registration is the same for both of them, so that they're provisionally approved for treatment of COVID-19 in adults who are at risk of symptom progression into hospitalization, not requiring supplementary oxygen. In the blue box next to this, I've included what was the inclusion criteria for the study, which was submitted as part of the registration. Clearly, that's a fairly broad criteria, and I guess if we're looking at how we're going to use what is a limited availability of these, what I know for a fact is that the National Clinical Evidence Task Force are going to be looking towards a narrower and fairly well-defined criteria based on risk-benefit, so that we prioritise I guess the availability to a slightly narrower group of patients than that initial inclusion criteria there. I think what's important for both the Molnupiravir and the I guess the Paxlovid, the combination product I'll talk around in a moment, is both of the registration documents were based on clinical trial data when Delta and its precursors were in circulation. They've both got established as having in vivo efficacy against Omicron, but clearly we're expecting real world data to be emerging. Similarly, that trial data for the registration did not include partially or fully vaccinated individuals, which are excluded from those trials. Now, the Molnupiravir is a ribonucleoside analog, which interferes with viral replication, probably in a manner that's unrelated to how an immune response is generated. However, clearly we need virologists and other opinions as to the likely efficacy in groups of staff that have been vaccinated, but on first impressions, you'd hope that would be likely. So in terms of efficacy, the study data for the Molnupiravir was looking at a 30% risk reduction of hospitalization and death. Just in terms of some of the practicalities, so the dosing we're looking at there is 4 200 milligram tablets need to be taken twice a day for 5 days, with that to be commenced as soon as possible after the diagnosis, which can either be PCR or RAT. And I guess that diagnosis needed to have been made within 5 days of symptom onset for that treatment to be commenced. Contraindications, drug interactions, those things we're still learning more around. Unless patients have a known allergy to either the agent in itself, which is unlikely, or its excipients, there wouldn't be another contraindication. Drug interactions, there aren't known drug interactions listed at this stage. And for the Molnupiravir, for hepatic or renal, there's no dose adjustments. When we're moving into the pregnancy and the breastfeeding side of things, unlike sotrovimab, it's category D in pregnancy, so it's not recommended, and women of childbearing potential should use effective contraception for the duration of their treatment and for 4 days following the last dose. Interestingly enough, there's specific recommendation around men as well, so it's not known if the Molnupiravir can affect sperm. But the recommendation at this stage is that for men who have sexually active with a partner of childbearing potential should use an adequate form of contraception, not just during treatment and not just for 4 days, but for 3 months after the last dose. So that's interesting. I'll just move on to the next slide, which is on to the combination product. So here we've got our Nimatravir and Retronivo, so Paxlovid. Again, the TGA recommendations is the same. And as I said previously, that final criteria is in which it's going to be made publicly available, and the guidance that will be coming through to not just our primary health networks and our GP forums, but also to the public hospital facilities is likely to be a bit narrower. Just in the conversations that have been occurring today, I think some of the intention of that is not just to target it against those who would serve best benefit, but there is a very clear understanding that there needs to be clarity to help support GPs in providing who is in scope and who is out of scope. And if we're under some pressure from patients that might be particularly interested in taking part of that, if we've got some clear criteria, then it certainly helps us be clear as to whether it's appropriate or not. So the Nimatravir, I guess this combination product is a protease inhibitor. It's got a low dose Retronivo in here, which is only really added to slow the metabolism of the protease inhibitor. So the intention there is obviously to increase the bioavailability, but I'll get into this in a moment. But the Retronivo is an active cytochrome P450, one of the enzymatic pathways in the liver, an inducer, which has a lot of meaningful drug-related interactions. So under contraindications, unlike the previous agent, this one is contraindicated if there's severe renal impairment or hepatic impairment with a severe renal would be less than 30 mils per minute on the eGFR, with a Charles-Pugh less than a class C for the renal side of things, as well as any significant drug-induced interactions. Again, that'll be on the next slide. The dosing on this one is 2 100 milligram tablets of the Nimatravir together with that low dose Retronivo. So you basically need to take those combinations every 12 hours for 5 days. Again, commenced as soon as possible after a PCR or a RAT positive, and that diagnosis needs to have been made within 5 days of symptom onset. The reduction for this one in terms of from a renal impairment is rather than taking 300 milligrams of the Nimatravir for patients that have a moderate renal impairment, that would need to be reduced to 150 milligrams. In terms of precautions, as I said, the Nimatravir is in a combination product with the Retronivo, which can interfere with HIV medications and can lead into development of resistance for HIV against some of our treatments. So HIV population is not appropriate for this combination therapy. Pregnancy and breastfeeding side of things is not recommended. So if you are pregnant, breastfeeding, or looking to start a family, you need to take, I guess our patients need to take preventative measures for a 7-day period after, not just whilst they're on treatment, but for that 7 days afterwards. Now I'll just move on to the next slide. Again, I won't dwell on this one because I think this will be much clearer in the information that will be coming through. But as I touched on, given the fact it's a combination product and that the Retronivo is a potent enzyme inducer, we have, when I added up through the list, there's 96 medications of which there is an interaction, and there's 21 of those which are contraindicated. And if we're looking at some of those there, like amiodarone, carbamazepine, simvastatin, diazepam, these are treatments that are fairly common. For some of those, I guess like the HMG reductase, the simvastatin, we may choose to discontinue therapy for a period of time if there's a meaningful benefit on this one. But for others, certainly the anti-epileptics or the antiarrhythmics, certainly that will present a bit of a challenge as to how we would manage that. So again, I think what would become clearly apparent is there are some particular limitations for this combination therapy. Its efficacy is good. I don't think I necessarily touched on that on the previous slide, but it's got an 89% risk reduction of hospitalization, which would be comparable with the sotrovimab, and is certainly better than the molnupiravir, which is the combination therapy, which has got that about 30% risk reduction. But clearly, the combination product has some less suitability in some populations, together with that risk of meaningful drug interactions. Mel, probably just onto my last slide. So in terms of access pathways, these are, as we talk, I think the last weeks, this has been fairly full on in terms of how we're going to make these available through to our population. Now, there is a PBS listing that's being lodged that in reality will probably take 4 to 6 months to come through. As a result, the CEC in their wisdom have determined that that will need to be supplied via the public hospitals. So we are seeking and waiting for further input from the ministry, but I believe, as of feedback from today, that the primary health networks will be issued with a fact sheet which is containing links to a number of resources. One of those will be a GP prescription and declaration combo form. I think Michelle, who spoke earlier, will be pleased to hear. I understand that's going to be hosted on the Health Pathways resource as well. Having had a sneaky screenshot of some of the data that's captured that the GPs will be requested to provide, it looks like it will have your usual patient name, date of birth, address. It'll also ask around the patient's vaccination status. There's a checkbox for relevant risk factors or comorbidities, as well as it will seek confirmation that the patient has an informed consent, and also confirmation that that COVID testing that you satisfied yourself that there's evidence of either a positive PCR or RAT. To access treatment, that prescribing declaration combo form would need to be sent through to the public hospitals, which is where we're needing to host and organise the supply of those medications. So as Mel said earlier, I think it's important that we stay with a single point of access, and things are confusing and complicated enough. So currently, I think we're getting good traction and access from the GP networks through to the community COVID support team. So we would like to still see that as that point of accessing through to the oral medications. So what we're highly likely to request, as we just confirm our logistics, is that prescribing declaration combo would be sent through to the existing email address. At that point in time, we anticipate coordinating the dispensing, getting in touch with the patient or a suitable carer to come and collect from an appropriate location. But I think the last thing I probably just want to mention is that whilst these oral therapies certainly provide an opportunity, the exact clinical criteria I think will drive a lot in terms of I guess demand through GPs, and it's also important to be aware that the sotrovimab has advantages. I think despite it being IV, we do have greater clinical experience with that. There's more of a known safety profile. It's got an efficacy at least comparable to the combination therapy, with that about 80% risk reduction of hospitalization, and it is suitable in pregnancy and adolescence. So these oral therapies are adding into our therapeutic armamentarium, but I guess as with any treatment, we've got to be mindful of the risks and benefits of each of those therapies. Okay, thank you very much. I think I'll hand over at this stage.
Thanks very much, Tim, and thank you everyone for your presentations. Mel and Elizabeth, that was really useful to get the updated information on the Central Coast, and it's great to hear we've perhaps got a bit more coordinated care. So congratulations on what's happening inside the LHD. So we don't have a lot of questions written up yet, but so I'd actually ask all attendees, if you've got some questions, please enter them into our question and answers question box or on chat, and we can take those. But I do have a number of questions that have been submitted before tonight, and Tim, my first question is to you. It's great to hear about your little insight into the GP script. Do you have any knowledge about when that will start? And will GPs actually need to be trained in it? The question is, we're being trained on how to do the immunisations. Every time a new immunisation comes out, we actually really need to have our certificate to show our practices. Will there be some education on this?
Yeah, look, I think that's a really interesting observation, the fact that whoever we are, both in the hospital sector and in primary care land, there is a very stringent expectation around training and credentialing around the vaccines. As far as I can tell, there isn't a mandatory training requirement around the oral therapies. The declaration form will be intuitive to the general practitioners in terms of completing it. It's not asking information that you wouldn't already be conversant with. However, I'm not aware of, I'm not sure whether Michelle or John would, but certainly the GP and the primary health networks have formed part of the consultation process. So whether there's specific training materials or resources, I would hope so, but I don't think that is a prerequisite to prescribing the medications. And as I said, I think the declaration form, the prescribing is fairly intuitive. Clearly, I think we've got to be confident as to exactly what are the clinical criteria so that it's not vague as to who we should be prescribing it in.
Thanks, Tim. I guess we're just watching in anticipation. There's certainly been a little bit of information to general practice. Professor Kidd had a webinar last Friday, Michelle, I think it was. So I'd take you there. The college is certainly talking about this, and for those interested, tomorrow night there is a college update through the RACGP. I'd really recommend that those who would like to go online and be part of that webinar. Just to warn you that sometimes when it's very overprescribed, we don't all get on, but it will be recorded. So it's going to be quite useful, I think, for general practice. There's a really good panel on there. Coming back to John and Michelle, a couple of questions about Novavax. Some practices asking, how do we know which tranche we're in? Have practices been informed about that when they first gave their the information back to the PHN? Not all practices know about what tranche they are. And when will Novavax be delivered? John?
Sure. So just in terms of so those practices who submitted an EOI will have received an onboarding letter for their commencement date, either tranche 1 or tranche 2. So that was the Novavax was weighted towards rural and remote areas in terms of its initial distribution. So that's primarily the tranche 1s. The tranche 2, which is 1 week later, has been then the rest of the group. So anyone that submitted an EOI should have received their onboarding letter. If you submitted an EOI after the closing date, then you will be in the balance, which will be notified in the coming weeks. In terms of the delivery, so tranche 2 orders will be delivered in the week commencing the 18th, and I think the tranche 1s are the week prior to that. So, but we'll confirm that in an email tomorrow for those delivery dates.
Okay, there's been a couple of practices, certainly on the Central Coast, who are a little concerned that 100 doses, they're not going to have 100, they're not going to have 50 patients that they can think of. So we are just going to our practices around us, and we're going to divide those 100 doses amongst those practices who would like them, so that we can order them amongst us. Is that doable, John? We can share these.
Yeah,
doses,
absolutely.
Yep.
Yeah, absolutely. The only requirement is that any site receiving a supply of Novavax, either directly from the Commonwealth or by some sharing arrangement, they need to have done the training and they need to have signed the site declaration for Novavax. So once they've done those two, if your practice wants to order them and then distribute them and manage that cold chain process, yeah, absolutely. And just remember that you can order in quantities of 100 beyond. You can also, skip an order and place orders as you require it. But sharing is probably the best way to do it, and you can do that. Just remember cold chain. Remember they need to have signed the declaration and they need to have done the training.
Thanks, John. Michelle, can you just inform us again about a patient with COVID who's due for a booster? Yep. When is the best time for them to be boosted, please?
Okay, so there's lots of answers to that, aren't there? Okay, so there is no immediate rush to boost these people. They have some immunity from their recent infection. At the same time, if they really want to be boosted as soon as they come out of isolation, they can be. There's nothing dangerous in that. The optimum timing is probably 4 to 6 weeks, as discussed by Kerry Chant a few weeks ago. So 4 to 6 weeks post. You can postpone for up to 4 months with a temporary exemption, with the correct bit of paper filled in by your poor GP, who then has to battle with PRODA to get it submitted. So, but why would you when actually the advice is get vaccinated? Long answer, short question, short answer, 4 to 6 weeks.
Yep, no, that's great. Thank you. And I guess as long as they're over their infection, and don't come close to a general practice, because it's a high risk setting on day 7 or day 8 to be vaccinated.
That's right. Yeah. That day 8 to 10, when they're out and about, you don't want them in your general practice really. And there isn't any reason for them to be there to be boosted. It's, people are trying to do the right thing, but it's actually not necessary at that point.
Yeah, yeah. Question for Mel and Elizabeth. Referrals to the CCST on the Central Coast. How do GPs know that you've received the referral if it comes by email? And how do we know that our patient is being contacted? At times, some of those referrals are coming through and we don't get replies. So is there a return reply to us just to say, yes, received, would be really useful. is the statement.
Yeah, it's Mel here. So in regards to that, it's when the numbers were really low, we did make a conscious effort to reply to our GPs that were referring in to make sure that they were aware that we had their patient and that we had followed up with them. It did become quite challenging, and even now I did a bit of a review of the referrals that were coming through from some of our GP practices on the Central Coast today. And some of the referrals that come through actually have a stamp at the bottom that says, do not reply to this email. So I don't know if that's sort of, no one monitors that reply side. So it is quite challenging, I do admit. And it's something, look, we can go away and look at it a bit more, but it is challenging to try and communicate back to all the GPs. And sometimes we have patients that don't have GPs.
Yeah, I guess the GP who's asked this question is referrals have been made, and unless the GP themselves calls the patient back, they don't actually know whether or not the team has actually been in touch. And that could well be that maybe the patient didn't need to be, or that the GP is just not sure where they're sitting. And I guess it's just sometimes worthwhile that closed loop of communication, which is GPs, we often do fall into has something gone out, the referral gone out into nowhere, or is it actually being seen? And it would be some feedback to your team that I think we do need, even if it's just a reply, received, thank you.
Yep, received and actioned. Yeah, no, that's fine. Karen, we can do that. It's just there'll be some that where it does say do not reply to this email, so we don't know if that's been monitored back at the GP practice end. But I can certainly provide that feedback to the team, and I think that's doable.
Great. And Elizabeth, elderly patients, over 60, 70, particularly probably in their 80s and 90s, we're hearing more and more of them COVID positive, not too symptomatic, perhaps in the first couple of days. Are they people who have been identified by positive rats through from Medibank? Are they being a CCST automatically being informed about them, or does their GP need to send a referral in for these people who may be living alone without many social contacts?
Yeah, Mel can help with this as well.
Yeah.
But I mean, if they come through, because it's an opt-in system, that is a very vulnerable group. I've had, they sometimes only get around to asking one of the grandchildren to send in the reply when they start feeling sick. So we sometimes only get them later. So because it used to be, we knew about all of them, they all came onto the patient portal, we could put in a filter and look at everybody over 70, but we can't do that anymore. So it's a weak link, I think, in the new system, Karen, that we don't necessarily, if we hear from them, definitely they'll be in CCST. Or am I right, Mel?
Yeah, that is right. So, but however, what I can update is that it has been recognised around the state that this is a group of vulnerable patients that don't necessarily refer in or contact a GP or Medibank to raise any concerns. So I do know at a state level this was only a discussion today, so it's very fresh, they were looking at how we might be able to engage, I guess, that Medibank to call back for, and looking at over 70s was the age they were looking at, is there a way we can actually reach out to those people just to see how are they travelling? Do they need to be linked in with their local health district for ongoing support and monitoring?
Yeah, just to let you know, there is a question about the webinar tomorrow night for the college, and we have put up there the direct link. Apparently the registration has closed. It may well have been that there's a lot of people interested, but don't despair. It will be recorded. We have been promised that it will be recorded and will be available usually within 24 hours. So once we've got that recording, we can perhaps pass it through to PHN as well, and we could put that up in response to tonight. Another question to Tim. Tim, is it possible to have a link to the full list of drug interactions from the table you showed?
Yeah,
please?
I can certainly provide through to, I guess, either John or Charles.
Charles. Yep.
Yeah, I've got some resources from the CEC, so I'm happy to email those through.
Fantastic. And John Bailey's just given us a bit of information about delivery dates for Novavax. Tranche 1, which is predominantly going to the rural sector, will be from the 18th of February, and Tranche 2, the week ending on the 25th of February. So thank you for that, John. I guess, Mel, just, a comment about if you're only really receiving 5 referrals on emails from GPs a day, if you could get some form of reply, a formal reply, I think that would be really helpful for those of us who are using an email system.
Yeah, when it comes to email, I'm happy to follow that up. I guess just to keep in mind the context of we're also getting the many referrals through Medibank, and what we didn't touch on is the patients that are still sitting there to be registered. So yeah, but yeah, certainly where we've got an email address that we can reply to, I think that's very doable.
Okay, and of course, all of the presentations tonight will be on the education portal. So we are actually now up to 7:30, which is the end of tonight. So thank you very much. I'm going to just hand back over to Charles. But again, a really informative night, and I thank you very much, Mel, Elizabeth, and Tim, for coming online from LHD on the Central Coast. And once again, our guru Q&A, Michelle, keep those questions coming. And John Bailey's always got lots of great insight. So over to you. Thanks, Charles.
Thanks, Karen. Thank you so much. And of course, I extend my thanks to all of our speakers tonight. Really appreciate you taking your time out of your busy schedules to prepare your content and present. And of course, thanks to you all out there for giving your evening to spend it with us and for all your great questions. So we appreciate that. So yeah, there was a question I saw around the PowerPoint presentations becoming available. So we will have those up with the recording tomorrow in the Education Library on our website. So yeah, if you have any colleagues that missed it tonight and like to rewatch it, we will have that recording available. Just a quick reminder that an evaluation survey will shortly pop up when I end the webinar. So if you could just take one more minute of your evening to fill that out, we really appreciate your feedback. Our next Living with COVID webinar will be held in a fortnight, so Tuesday the 22nd of February. So just keep an eye out. We'll have that flyer out with the link to register. So definitely encourage you to come along and keep informed. That's all from me. Thanks again to everyone for joining us and to our speakers, and we hope you enjoy the rest of your evening. Good night.
Thanks, Charles.
Night, everyone.